uveitic glaucoma, or other times a very experienced ophthalmic surgeon may use as a first option to treat a uveitic glaucoma the use of a shunt or even a MIG. So our next speaker is a very experienced ophthalmic surgeon. He's the head of glaucoma department in the University Eye Clinic of Geneva, with a great experience in the use of shunt and MIGS. I would like to welcome Mr. Shaarawy. Bonjour Tarek. Merci pour l'honneur d'être avec nous aujourd'hui. So please, Mr. Shaarawy.
Let me try to share my screen. Let's see. Does that work for you? Can you see my screen?
Yes.
Okay, so you see my slides?
Yes.
Very good. Okay, so I can start. Professor Moscos, Marilita, it's an honor to be with you. Thank you very much for the invitation. I was hoping to be physically with you today in beautiful Greece. I have a long history with this beautiful country and its glaucoma community. Unfortunately, we had instructions from the university not to travel yesterday, so I couldn't travel this morning. And just an hour ago, the whole country reversed its position and is allowing people to travel without quarantine. So it just tells you how politicians can make life very difficult for us. So I'm going to speak about surgical options related to uveitic glaucoma. And you know, the dilemma is that glaucoma is a very common complication of uveitis. A lot of what I'm going to discuss now will follow on the same lines as my previous colleague who gave an exceptionally good presentation. I would like to just try to give my 2 cents of idea from a little bit a different angle. Uveitic or inflammation in the eye can destroy the outflow pathway and is in many cases treated with corticosteroids that can increase the intraocular pressure in patients who are steroid responders. When we opt for surgery, the dilemma is that we often have an excessive healing and scarring after the operation, or we can meet with severe hypotony. So the numbers basically are the following. 25% of people with uveitis would develop an elevated intraocular pressure at some point during their course of the disease, and the prevalence of secondary glaucoma among uveitic patients can go all the way from 5 to 27% based on many things, including the type of uveitis itself. Among uveitic patients, about 1/3 will end up having a glaucoma surgery. Now, the dilemma or the tragedy of this problem can be expressed when we look at the results of juvenile idiopathic arthritis in children, where 35% of children or of adolescents will end up with loss of vision. What kind of uveitis we're facing and the angle structures, this has been very well described by my previous 2 colleagues, so I'm not going to go into details, just to tell you that, of course, what makes a big difference is the angle open or not, and if it is open, to what extent, and if it is closed, to what extent. Now, the rule for uveitic glaucoma is first and foremost to treat inflammation, to reduce inflammation. But that does not work for all of our patients. And if you find a synechia that has resulted in a pupillary block, so you should rely not just on medications, but an iridotomy might help. Iridotomies can solve the problem in many cases, but the results of iridotomies in uveitic glaucomas are not as good as in primary angle closure glaucoma. We always try to treat intraocular pressure and reduce it as long as it's transient. If we feel that the pressure of the eye will continue to be high with maximal medical therapy, then we obviously have to operate. The question is, we do not want to do something as an operation that is irreversible in a condition that can be reversible. So the question is always in front of the uveitis specialist and the glaucoma specialist is to operate or not to operate. So 3 questions that we need to ask each other or ourselves is IOP increase reversible or not? How is the state of the angle and how is the state of the conjunctiva? And you know that there are high risk factors for failure with whatever type of glaucoma surgery that you're going to do in uveitic cases, especially if they are young in certain ethnic groups, in Asians and Africans specifically, if there is active inflammation or not. So you are very well encouraged to dampen inflammation with all the weapons in your armamentarium before you start, before you take the patient into the operating room. And there is a high risk of iris incarceration, so you can opt for surgeries that does not require iridectomy or iridotomy, which is always better. Consider other ocular comorbidities, things that are affecting not just the angle, but also affecting the lens and affecting the cornea, and prioritize according to the interest of the patient. In most cases, we have to give the priority to intraocular pressure because you cannot really manage a good keratoplasty or any sort of grafting without having a good intraocular pressure. And as the ciliary body is affected and is inflamed, there is obviously a risk for hypotony. One of the mechanisms will be a ciliary shutdown. This is all the types of glaucoma surgeries that we have now. You see, there are many operations that we can do, and I'm not going to go into all details, obviously, because we don't have time for that. But just to give you a few examples or a few hints, I always take the time to expose the site of surgery very well. You see here a speculum that I have designed a couple of years ago. I use an 8/0 vicryl put diagonally, and I fix the eye completely and pull the globe downwards to give me a complete exposure of the dissection site. I need to operate in whatever type of glaucoma surgery, obviously, in a good exposure. In uveitic glaucoma, the eye is red, the eye is not very quiet. You need to look very well. And then it is very important before you operate is to assess the conjunctiva. I do all sorts of tests to look at the conjunctiva, its mobility. Is it thin? Is it atrophic? Is it scarred? This changes completely what I want to do to my patient. And then I start all types of glaucoma surgeries, of course, uveitic glaucoma included, with injecting of BSS under the conjunctiva, so doing a hydrodissection of the conjunctiva. And here it is not really a dissection per se. I'm not injecting so that the conjunctiva separates from the tenon or from the sclera. I'm injecting so that I get to identify with the conjunctiva and identify what kind of conjunctiva I am dealing with. Once I do that, there are some intraoperative considerations that you should consider: mitomycin dosing and what kind of mitomycin duration and concentration. Most surgeons now that are handling difficult cases of uveitic glaucomas will use 0.5 milligram per milliliter for 3 minutes. That is much higher than I use with primary open-angle glaucoma. Try to avoid iridectomy because that can entice a new episode of inflammation in the eye. And if you are going to rely on a trabeculectomy, you may opt for putting more sutures or releasable sutures that you can then take out so that at the end of the day, you avoid hypotony. And there is a very good argument for using corticosteroids at the end of the operation. Some people will use it intravitreal, some people will use it intracameral. I'm not very much for intravenous ones, but also periorbital steroids at the end of the operation. If you are opting for something like a trabeculectomy, a lot of surgeons will continue to give atropine in the post-operative period. And as you are already operating and opening the eye, make sure that you get an aqueous sample that can help you a lot in the diagnosis of what you had. of what you have. I will speak a little bit about non-penetrating glaucoma surgery because I think it's a very interesting procedure in uveitic glaucomas. The potential advantages are it is non-penetrating, so you don't open the eye. The inflammation in the eye is much less. There is a trabeculodescemet membrane, as you can see. Oh, let me go back. There's a trabeculodescemet membrane that will avoid or create a potential barrier that will reduce inflammation access into the bleb and will lower the risk of endophthalmitis. You don't do an iridectomy, and the risk of severe hypotony with loss of antechamber is much less with a deep sclerectomy compared to trabeculectomy. Obviously, deep sclerectomy is technically challenging and a difficult procedure. But if you invest the time and the effort to do the operation, I can promise you that at the end of the day, you have an antechamber that is absolutely full and keeping with its well configuration, so you do not develop a loss of antechamber and all the mess that can happen from profound and severe hypotonies. Those don't happen after deep sclerectomy. You can see here, we are opening Schlemm's canal, and then here we are actually pulling on the inner wall of Schlemm's canal and the juxtacanalicular trabeculum, the site of obstruction in secondary open angle uveitic glaucoma cases. And if you analyze this membrane that you are taking out, which is the trabeculum, basically you can see signs of severe inflammation in cases of uveitic glaucoma. As you can see here, aqueous is coming out, it's percolating, the antechamber is full, and we close the superficial flap with just a little bit with 1 or 2 stitches. We don't need to close it tightly, and we enjoy an operation that really works well for uveitic glaucomas. If the pressure starts to go up, you can always do a goniopuncture. Here's a case of goniopuncture in a uveitic glaucoma. You can see the pressure has been going up, so we decided to do a goniopuncture. We focus with the YAG on the trabeculodescemet membrane or the trabecular window, as you can see, creating micro holes, which allows for reduction in intraocular pressure. I'm not going to go a lot into trabeculectomy. My colleague did a brilliant job with a very, very nice presentation about trabeculectomy. Just remember that trabeculectomy for uveitic glaucomas can be indicated in cases where the conjunctiva is in a very good condition and the uveitis is well controlled. But many people will opt for starting with a tube, especially if we already tried the trabeculectomy and it doesn't work, or if we think that a trabeculectomy or a deep sclerectomy will not work for one reason or another. So there is a good argument for us to go immediately for a tube. This is how I put a tube. As you can see, I'm going to run to give you, for the sake of time, you can see I'm doing 8x11 flap. It's quite a wide flap here. And then I dissect a deep scleral dissection, which is, I call this technique the envelope and trench. So you see here, we created a big side envelope, side flap, and we are now creating this trench, as you can see, where we basically create a deep pocket or a deep area for us to put our tube. We create our tunnel inside the antechamber and slowly thread in the implant, as you can see. And then, easy enough, we close this flap with 210-0 and close the conjunctiva. It takes about 20 minutes to put a tube in that way. I've tried Zen implants in uveitic cases. My results have not been satisfactory. I've tried the microstent and with mitomycin and very vigilant post-operative follow-up and steroids for a long period of time. The results so far are decent. There is one study that came, a poster actually, I don't know if it has been published, that came from Moorfields on the use of pressure flow, and they also reported interesting results with those. I mean, this is not the end of the line and it's not the holy grail, but it is a procedure that is easy to do without having to do iridectomy, and the chance for hypotonies are very low because the diameter of the tube is very small. It also gives you a very nice as you can see here, flap that is, you know, diffuse, not too prominent, and you can actually give your patient the opportunity to wear contact lenses. So in terms of post-operative consideration, it is extremely important that you manage those cases post-operatively with the uveitis specialist and consider to give more continuous topical periocular or systemic steroids in some cases. If you have signs of scarring, you have to intervene early. Don't wait for scarring to set in and then you will not be able to break it. So 5-FU or mitomycin. And you have to manage hypotony aggressively. Increasing steroids, putting atropine, giving even low or giving injections of viscoelastics inside the antechamber to break the cycle of hypotony and reduce choroidal effusion. And finally, the take-home message, try to optimize the therapy for glaucoma, for the uveitic glaucoma, first of all, through medical and laser therapy. Glaucoma surgery in uveitic glaucomas is not a walk in the park. It is a difficult operation and better avoided if we can. And optimize the inflammation prior to going into surgery. And remember that despite that surgery does not always end in a perfect situation with in uveitic glaucomas, they still have an extremely important role, and I would really like you to consider non-penetrating surgery. There are lots of studies in publication or actually in the literature that shows very good results with deep sclerectomy. And finally, be aggressive with hypotonies just as well as being aggressive with scarring. With that, I thank you very much for your attention. And again, thank you very much for the invitation. I really wish that I was in front of you now in your beautiful country speaking, but I'm hoping that I will still get an invitation sometime in the future where traveling and face-to-face meetings become more frequent. Thank you once again.
Thank you very much, Tarek, for your excellent presentation, your brilliant videos that you showed to us.